Good afternoon, everyone, and welcome to today's Fireside Chat in honor of Breast Cancer Awareness Month. I'm Amna Hussein, the Community Outreach and Engagement Manager at the Masonic Cancer Center at the University of Minnesota, your host and moderator for the Fireside Chats each month. Today, we're shedding light on triple-negative breast cancer in honor of Breast Cancer Awareness Month. It's an aggressive type of breast cancer that disproportionately affects younger women and women of color, particularly Black women. These disparities highlight the urgent need for research, education, and access to equitable care, especially here in Minnesota, where we see our communities continuing to experience gaps in screening and outcomes. Our conversation today will connect the science behind triple-negative breast cancer with the lived experience of those impacted by it. The Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. Our office serves as a vital bridge between the Cancer Center and communities across the state of Minnesota and beyond. Our small but mighty team is committed to reducing the burden of cancer by actively engaging communities and providing access to relevant knowledge on the latest in cancer research, prevention strategies, the importance of screening and early detection, treatment options, survivorship, and opportunities for clinical research. Each month, we host these fireside chats to bring the science and community together to share knowledge, raise awareness, and highlight the people and research driving change across the cancer continuum. It is now my pleasure to introduce our speakers today. First, we will be hearing from Dr. Deepali Sachdev, an assistant professor at the University of Minnesota and research member of the Cellular Mechanisms Research Program at the Masonic Cancer Center. Dr. Sachdev received her PhD from the University of Texas Health Science Center at San Antonio, and is an active member of the American Association for Cancer Research and the Endocrine Society. At the University of Minnesota, her research focuses on triple-negative breast cancer with an emphasis on understanding why it disproportionately impacts Black women and identifying new molecular targets to improve outcomes for all triple-negative breast cancer patients. Today, Dr. Sachdev will provide an overview of triple-negative breast cancer, and she will also be sharing how her research is working to better understand and treat it. Joining Dr. Sachdev is Katie Lin, a triple-negative breast cancer thriver, a working mom, an IT business analyst from Minneapolis who enjoys reading, knitting, and exploring new creative hobbies. Katie's cancer journey through diagnosis, treatment, and survivorship is one of strength and perseverance, and today she will be sharing her personal story with us. We're so grateful to have both of them here with us today. And before we dive in, I'll just cover a few quick housekeeping items. Today's Fireside Chat will be recorded, as they always are, and will be posted to the Masonic Cancer Center's YouTube page. Closed captioning is available for this session, so you can turn it on by clicking the CC button at the bottom of your Zoom screen. For University of Minnesota employees and spouses participating in the university's Employee Wellbeing Program, you can claim your 200 Wellbeing points for attending today's Fireside Chat by completing the form that I will drop in the chat shortly. And we invite you to engage with us. So please use the Q&A feature to submit any questions or comments you have throughout the session. We have some time carved out at the end to take some questions with our speakers. And without further ado, I will now pass the virtual floor over to Dr. Sachdev.
Good afternoon, and thank you, Amna, for that introduction, and thank you everyone for joining us today. As Amna said, my lab works on breast cancer, and we focus on triple-negative breast cancer as well as hormone receptor positive breast cancer metastasis. Amna, it won't forward again, the slide.
All right, I will have it up.
Okay. I'm going to stop sharing then. Thank you. So as many of you are probably aware, breast cancer is the most common cancer diagnosed in women. And this is shown on the left, which shows the estimated number of new breast cancer cases in 2024. It is also the second highest cause of cancer death amongst women, as shown by the estimated number of cancer deaths on the right here. Lung cancer is the leading cause of death in females as well. So breast cancer is divided into several subtypes, and this is based on the gene expression profiles of these cancers. The most common type of breast cancer is known as estrogen receptor positive or hormone receptor positive, and it is shown here as ER positive. These cancers express the estrogen receptor and the progesterone receptor, and the hormone estrogen drives their growth. A second subtype of breast cancer is known as HER2 amplified, and this subtype expresses a growth factor on the surface of the cancer cells. The third major subtype of breast cancer is known as triple negative, and that is the focus of today's presentation. It accounts for 15 to 20% of cases diagnosed in the US. Triple negative breast cancer is so named because it lacks the estrogen receptor, the progesterone receptor, and HER2. And therefore, up until recently, had very limited targeted therapy choices, as we were still trying to understand what markers we can target for triple negative breast cancer. Triple negative breast cancer, which is also often referred to as HR negative and HER2 negative, can be aggressive and difficult to treat. It is more likely to be higher grade and more proliferative with a higher risk of recurrence. It's very commonly diagnosed in women under the age of 40, and early systemic treatment is key in improving outcomes. When it metastasizes, the most common sites of metastasis include the liver, lungs, and brain. Next slide, please. And as Amna mentioned, it disproportionately affects women of color, in particular, non-Hispanic Black Americans, as shown here. So this is a slide that shows the percentages of the various subtypes of breast cancer by race and ethnicity. So the colors in red represent the hormone receptor positive breast cancer. The dark gray represents triple negative breast cancer. And as you can see, non-Hispanic whites have the highest proportion of hormone receptor positive breast cancers. And in contrast, triple negative breast cancer disproportionately affects non-Hispanic Black and other women of color. Next slide. So 85% or 95% of triple negative breast cancers are actually diagnosed early during stage 1 to 3. And stage 1 is the very early stage of breast cancer, and stage 2 is where it's still restricted to the breast and involves lymph nodes. And stage 3 is where it's considered regionally spread disease. 5% of breast cancer are diagnosed as metastatic stage 4. And of these, 20% will relapse at some point. So currently for breast cancer, the survival choice options are pretty good when the disease is diagnosed early. It is when it spreads and gets metastasized that we have not so great at being able to treat it. And there is a wide difference in the latency of recurrence in breast cancer. Shown here is, next slide, please. You can skip this one. Next slide. So this shows you the latency of metastasis based on the type of breast cancer. So along the axis here, you can see the time to metastasize, and this one shows you the frequency of metastasis. For breast cancers that lack the estrogen receptor and are represented here as ER minus, you can see they have a fairly early relapse, and the relapse happens anywhere between 1 to 3 years of diagnosis. In contrast, patients who have estrogen receptor positive breast cancer can have a very prolonged latency for recurrence, which often can spread from 5 to 20 years. Next slide, please. What you're seeing here is the relapses for triple negative breast cancer and HER2 amplified breast cancer. And you can see by the line in red, almost all of the relapses for triple negative breast cancer are fairly early relapses for the vast majority, just like for HER2 amplified breast cancer. Next slide, please. So currently, triple negative breast cancer has a couple of 3 or 4 treatment options. One of them is chemotherapy. The second is immunotherapy. And as you are aware, immunotherapy has been very successful in several solid cancers, including melanomas and non-small cell lung cancer. Immunotherapy uses a patient's own immune cells to fight the cancer. And a third group of drugs that has seen a remarkable success in triple negative breast cancer are known as antibody drug conjugates. Next slide, please. This shows you the prognosis as well as likely response to benefit from chemotherapy for the different subtypes of breast cancer. So the first 3 listed here are all hormone receptor positive breast cancers, which are divided into different subtypes, but we are going to just consider them all as hormone receptor positive breast cancer for the purposes of this slide. As you can see, the prognosis decreases as we go from hormone receptor positive breast cancers to triple negative breast cancers. In contrast, the benefit from chemotherapy increases as we go from hormone receptor positive breast cancers to triple negative breast cancers. And up until recently, triple negative breast cancers were indeed treated with only chemotherapy. Next slide, please. This is just a schematic to show you how triple negative breast cancers are treated currently. For patients who are at the stage 1, they are treated with a chemotherapy for 12 weeks, and then they switch the chemotherapy for another 20 weeks. For patients who are diagnosed at stage 2 or 3, currently the treatment includes 2 different chemotherapy agents as well as an immunotherapy agent. This is pembrolizumab, which has been approved for triple negative breast cancer. And then they switch the type of chemotherapy, but still continue with pembrolizumab, which is the immunotherapy that is used for triple negative breast cancer. Next slide, please. So this is just to show you the design of a clinical trial that actually led to the approval of pembrolizumab with chemotherapy for early stage triple negative breast cancer in the neoadjuvant treatment setting. Neoadjuvant treatment refers to treatment that is given before any surgery. And I just want you to point out that all of the clinical trials that are conducted are given names, and almost all of the clinical trials that involve this drug pembrolizumab have been named KEYNOTE with some number following that. So in this trial, it included newly diagnosed triple negative breast cancers patients, and patients were either treated with paclitaxel and carboplatin for 12 weeks and then switched to adriamycin and cyclophosphamide. And they were then either also given pembro or just placebo. And patients then underwent surgery because this was a neoadjuvant setting. And then after surgery, they were continued with the single agent immunotherapy. And at the end of the study, they looked at what is known as pathological complete response. Next slide, please. And this is shown here. The bar in cyan are patients that received the chemotherapy plus the immunotherapy. And the one in purple did not receive immunotherapy. And what you're seeing on this axis is the response. So this is known as pathological complete response, where they look at to see if they can find any tumor cells after the treatment. And as you can see, patients who were enrolled in this trial and received the combination with the immunotherapy had a better response. Next slide, please. And based on this, pembrolizumab was approved for triple negative breast cancer for high-risk early-stage triple negative breast cancer in combination with chemotherapy in the neoadjuvant setting. And we are going to continue discussing it in a little bit, at that it was also approved for treatment for metastatic triple negative breast cancer. Next slide, please. So at this point, we've discussed that early-stage triple negative breast cancer currently is treated with immunotherapy and chemotherapy combination. So today, if we were to take a question that is asked of medical trainees, we should be able to answer this question. So if the question is that a 34-year-old woman notes an enlarging left breast mass. A mammogram shows the left breast has a tumor spanning 6 centimeters, and ultrasound demonstrated enlarged axillary lymph nodes. Biopsy revealed a differentiated infiltrating ductal carcinoma, which is breast cancer. And her breast cancer was estrogen receptor negative, progesterone receptor negative, and HER2 negative. So it's a triple negative breast cancer. Biopsy of her lymph node confirmed malignant involvement, and CT imaging and a bone scan showed no distant metastasis. So essentially, this is a patient with early stage high-risk triple negative breast cancer. So if the question was, what neoadjuvant chemotherapy regimen do you recommend for a patient with node positive triple negative breast cancer? I think all of us would be able to answer that the last choice, which is the choice, can you hit enter? This would be the correct choice, right? Based on what we just discussed, that this patient should get chemotherapy in combination with immunotherapy. Next slide, please. So in order to develop this immunotherapy agent, researchers also looked to find what markers of response can we use. So they looked at several things, and the marker of response that they found was the most suitable was PD-L1, which is a marker that's present on the tumor cells. Next slide, please. So this is the marker that was selected as being indicative of response to this drug. So this drug blocks a cell surface marker on T cells. And this protein, PD-L1, is present on tumor cells, and it is the protein on the tumor cells that binds to the T cells. And they found that when they looked at the expression of this protein, PD-L1, it was related to response. Because this protein is detected by a technique called immunohistochemistry, where a section of a patient's tumor is taken and stained with an antibody that recognizes this protein, there can be a lot of variation depending on where the assay is conducted. So they have developed a technique, a score called complete positivity score to quantitate the expression of PD-L1. And it was found that when the patient has a CPS score of greater than 10, they had remarkable response to the addition of this immunotherapy to the regimen. Next slide, please. So this is a trial where they tested this addition of the immunotherapy to chemotherapy in metastatic triple negative breast cancer. And they also wanted to verify that this PD-L1 score would be related to response. So these are patients that had metastatic disease, and they enrolled all patients who had a tumor PD-L1 expression score from anywhere from less than 1 to more than 1. And once again, patients were provided chemotherapy with the immunotherapy drug or just the chemotherapy alone. And then they looked at overall survival in this study. Next slide, please. So this slide demonstrates that pembrolizumab increased overall survival in triple negative metastatic breast cancer by several months. For instance, it was 23 months for patients who got the immunotherapy versus 16.1 months for patients who just got the chemotherapy. And I just want to show you one example of the kind of data that clinicians look at after the clinical trial. So this is what is known as a Kaplan-Meier curve, where they look at the probability of survival. And the line in green are patients who received the immunotherapy. And as you can see, there is a higher percentage of patients that are surviving with that immunotherapy compared to the arm that got only the chemotherapy. So based on such studies, pembrolizumab was also approved for treatment of metastatic triple negative breast cancer with chemotherapy. Next slide, please. So the other class of drugs that has had a lot of success in triple negative breast cancer recently are called antibody drug conjugates. And our antibody drug conjugate is a drug where an antibody that would bind to a marker on a tumor cell is directly linked to a payload, and the payload is often a chemotherapy agent. So in the case of this chemotherapy drug, next slide, please. So this is just a structure of the ADC that we're going to talk about. So this is the antibody that binds to the protein TROP2 on the surface of triple-negative breast cancer cells. And this is the chemotherapy agent that is linked to the antibody directly. And the chemotherapy is attached to the antibody via linker. So the advantage of this is that it provides a more specific delivery of the chemotherapy to the tumor cell because the antibody will only bind to the tumor cell. Amna, can you go back one slide? So the way this molecule works, it binds to the surface of a tumor cell, and then it undergoes a process that is called internalization, where the receptor which it binds to and the antibody get taken inside the cell. And in an organelle inside the cell called the lysosome, the antibody is released from the chemotherapy, and the chemotherapy can then bind to the enzyme called DNA topoisomerase 2 and prevent cells from dividing. So this is the mechanism of action of an antibody drug conjugated. In addition to that, if the chemotherapy can diffuse out into the adjacent cell, it can also cause cell killing by what is known as a bystander effect. Next slide, please. Next. So based on such studies with this ADC in particular is called sacituzumab govitecan. They conducted a clinical trial in patients with metastatic triple-negative breast cancer who had recurred on 2 prior lines of treatment. And you can see that patients that received the ADC had an overall progression-free survival of 5.6 months compared to patients who were taking a single-agent chemotherapy. And based on these data, this drug was approved for treatment of metastatic triple-negative breast cancer. Next slide, please. And you can see that this drug is now named Trodelvy, and it had demonstrated survival benefit in metastatic triple-negative breast cancer patients. And it provided an improvement from 6.7 months with just chemotherapy to 12.1 months. And in 2021, this was approved for metastatic triple-negative breast cancer. Next slide, please. So all of this suggests to us that triple-negative breast cancers can become responsive to immunotherapy. And so my lab has spent a lot of time working on identifying markers on the surface of triple-negative breast cancer that are abundantly expressed. In order to use an immunotherapeutic approach, we need a marker that's present on the surface of the cell. And the 2 markers that my lab works on are called IGF-1 receptor, or the insulin-like growth factor receptor. And the second one is the fetal form of insulin receptor. The fetal form of insulin receptor is present in fetal tissues, but is lost in insulin-sensitive adult tissues. It is then upregulated in cancers like triple-negative breast cancer. And another point is that insulin and hyperinsulinemia quite often drive metastasis in triple-negative breast cancer in African and non-Hispanic Black patients. So this is another reason for trying to use this marker to target therapy. So in order to understand the role of these markers in breast cancer metastasis, we use preclinical models to understand what happens when you have a functional marker and a marker and what happens when you inhibit this marker. Next slide, please. Next slide. So in this experiment, we implant tumor cells into the mammary gland of a preclinical model. We let the tumors grow, and then we have a cohort of mice that get no treatment or control treatment, and another cohort of mice are treated with an inhibitor of this marker, IGF receptor. At the end of the experiments, we harvest the tumors as well as the lungs of the mice. And what you're seeing on the left are images of the lungs from mice that did not get treated. And I don't know if you are able to see, I hope you can see these large white circumscribed nodules. These are the metastases that you can see on the surface of the lung in those mice that were not treated. In contrast, on this image on the right, you are seeing a lung from a preclinical model that was treated with the antibody. And here you do not see macrometastasis. We did find some micrometastasis, but the treatment inhibited metastasis in this model. So that suggested to us that the IGF receptor that is present on the surface is a good target for targeting immunotherapy. And it also plays a role in driving the metastasis of these in these models. Next slide, please. In this section, we also looked at the effect of this marker on bone metastasis. So what are you're seeing on the upper panel are images of bones of the mice. So on the left are mice that were treated with vehicle, and on the right are preclinical subjects that were treated with the inhibitor. And as you can see, when there is no treatment, this bone shows a lot of metastasis. A hallmark of triple negative breast cancer is that it forms both osteoblastic lesions where bone is formed, as well as osteolytic lesions where the osteoclasts eat the bone. And you can see there is a plenty of metastasis in this bone compared to the bone that was treated with an IGFR inhibitor. What I am showing below are also sections from the bone that was stained to see how the structure of the bone has been destroyed. Next slide, please. So I just want to show you what a normal bone would look like when you section it and stain it. So in a normal bone, you should see muscle. You can see the marrow space here that has a lot of cells. And then you can see mineralized bone. When a bone has been taken over with osteolytic metastasis or osteoblastic metastasis, what you see is that the bone marrow is completely replaced by tumor cells. And also the mineralized bone is lost. Can we go back, Amna? So what you are now seeing here is that in a section of a bone where there were lots of metastases, the bone structure is completely taken over by tumor cells. You do not see any marrow space, as well as the mineralized bone is destroyed. In contrast, when we look at the bone from a subject that was treated with the drug, you can now see that you can begin to see the bone, mineralized bone, and as well as the marrow space. So this implicated the IGF receptor in metastasis of triple negative breast cancer. Next slide, please. So at this point, we wanted to take a different approach to develop immunotherapy for triple negative breast cancer. We wanted to use natural killer cell mediated targeting of IGF receptor and the fetal form of the insulin receptor. And the reason for that was because all of the current immunotherapy drugs that have been created and tested are based on a type of immune cell called T cells. And so we wanted to use a different approach using natural killer cells to target triple negative breast cancer using the expression of the IGF receptor and the fetal form of the insulin receptor as markers to target the NK cells to these tumors. Next slide, please. So natural killer cells perform a lot of functions in the human body, including reproduction, autoimmunity, and they really play an important role in clearing viral infected cells, but they also play a role in tumor surveillance and clearance. They compromise about 4 to 15% of all circulating lymphocytes or blood cells in the body. And they do not require any receptor. So T cells need to bind to a T cell receptor. NK cells do not need to do that. And they have a broad range of activating and inhibitory receptors on their surface that drives their function. And the way they work is they have granules inside the cells that contain enzymes that can cause lysis or killing of cells. And these two are shown here as gramzyme and perforin. So essentially, when an NK cell gets activated, these granules can move to the surface, and then they can release these enzymes that will kill cells. Next slide, please. So in order for these NK cells to kill, they need to be activated. And the way they can get activated is they have a marker on their surface that is referred to as CD16. Many antibodies can bind to this marker and activate what is known as antibody-dependent cell-mediated cytotoxicity, or ADCC. So essentially, when this antibody can engage the CD16, it creates a synapse and activates the NK cells. A second way of activating NK cells is by the release of certain cytokines by other immune cells. And this such as IL-15 can activate NK cells. Next slide, please. So at the University of Minnesota, Dr. Jeffrey Miller and his group have developed a novel immunotherapy platform called tri-specific killer engagers. And we collaborated with Dr. Miller's group to make trikes that are specific for the IGF receptor or the insulin receptor A isoform. So as the name might imply to you, trikes are synthesized to include specificities for 3 different proteins or cytokines, and we use portions of well-characterized antibodies that can recognize markers found on NK cells and the cancer cells. So essentially, the goal of this platform is to bring NK cells to target cancer cells by engaging the NK cells with the markers on the tumor cells. And this will then create a synapse, and then the activated NK cells will then lyse the cancer cell that expresses a specific marker that the trike is targeting. Next slide, please. And this is a cartoon to show you how a tri-specific killer engager works. So on the left is an NK cell that expresses that marker we call CD16. And this is the receptor for one of the cytokines that this drug includes. On the right is a tumor cell. And we can suppose or imagine that this is a tumor cell that expresses IGF receptor. This is the trike molecule that you're seeing here. So as I indicated earlier, one part of this drug will bind to the natural killer cell. In the middle, we have a cytokine called interleukin-15 that is required for the survival and proliferation of NK cells. This end of this drug then recognizes the IGF receptor on tumor cells. Next slide, please. So this is what the IGF receptor trike that we generated looks like. So we used the smallest functional unit of an antibody against CD16. So this part would engage the NK cells. In the middle, we have IL-15, which is required for the NK cells to expand and proliferate. And the third part of this drug is this functional unit from an IGF receptor antibody. And together, this is the IGF receptor trike. So the advantage of this drug over a full antibody is that it's much smaller in size. So it allows it to better reach the tumor through the tumor microenvironment. And shown here in this cartoon is a breast cancer tumor cell that expresses IGF receptor on its surface. So when the drug binds to the NK cell on the other side and then recognizes the tumor cell because of this IGF receptor marker, it will cause cell death of this tumor cell. Next slide, please. So in order to make the insulin receptor A trike, we had to use a different approach. And the reason for this is that the fetal form of the insulin receptor is highly similar to the adult form of the insulin receptor. And we really do not want to hit the adult form of the insulin receptor, as you may be aware that insulin signaling is important in regulating blood glucose. So we had to collaborate with a chemical engineer to find a small protein or a peptide that can be very specific for the A isoform of the insulin receptor. And the structure of that is shown here. And so this is the sequence of this binder that is very specific for the A isoform. So we generated an IRA trike using the same approach where we used a portion of the antibody that recognizes NK cells. This has IL-15, and here we used this small protein binder to generate the insulin receptor A trike. So one of the first things we wanted to test was, can this trike actually activate the NK cells? And so to do that, can we go to the next slide, please? We used an assay that's used in the laboratory where we combine peripheral blood NK cells that are isolated from normal volunteers, and then we mix it with a target cancer cell. In this case, we use this cell line here that expresses both IRA and IGF receptor. And then we add a control or no treatment and the IRA trike or the IGF-1R trike. And we let these components mix together for 4 hours. And then we measure 2 different markers that are indicative of activation of NK cells. And as you can see on these right panels here, both the IRA trike and the IGF-1R trike caused an increase in the marker that reflects activation of the NK cell compared to no treatment. Similarly, when we looked at the second marker of NK cell activation, we saw a similar trend where both the IRA trike in blue and the IGF-1R trike in green was able to increase the activation marker for NK cells, suggesting that this drug can indeed activate NK cells. This on the left are just controls where we do not have any cancer cells. We just have the trike and the NK cells. And you can see you get very little basal killing that is due to natural cytotoxicity that the NK cells have. But this still doesn't tell us if these drugs can actually kill tumor cells. Next slide, please. So in order to see if these trikes can kill triple-negative breast cancers, we decided to use a newer system called patient-derived xenograft organoids, or PDXOs. And the reason for this is, unfortunately, there are very few breast cancer cell lines that have been established from Black triple-negative breast cancer patients. So we established a collaboration with a researcher in Houston who has a lot of these patient-derived samples that were established from Black triple-negative breast cancer patients. So what they do is they obtain the tumor samples from the surgery, and then they can serially transplant it into a specific mouse. And then we remove the tumors from the mouse, and we can establish what are called organoids in the lab. So these are three-dimensional structures that you can grow and maintain in the lab. And then you can study the effect of these drugs on the growth of these organoids. So in the next slide, I'm showing an example of the effect of the IGF-1R trike on a patient-derived organoid. This was an organoid that was derived from a Black triple-negative breast cancer patient. On the left, you are seeing these three-dimensional structures called organoids in the absence of any treatment. On the right panel, you are seeing the effect of the trike. So in this side, we have added human NK cells and the trike, because the trike needs to activate the NK cells, which will then kill the tumor cells. And as you can see, the number of organoids and the size are much smaller in this treated side. So we are currently continuing to develop more organoid systems from triple-negative breast cancer patients, both Caucasian and African American or Black, so that we can test to see if these trikes can be beneficial for killing triple-negative breast cancer cells. Next slide, please. So the other thing that I talked about was that for immunotherapy to be successful, they needed to identify a biomarker that could be measured in patients. So we have tried starting to measure, to determine if we can measure these markers that we have selected to target the NK cells. And also we would like to identify other proteins that we can measure in one section from a patient's tumor. So these are archived formalin-fixed paraffin-embedded sections from triple-negative breast cancer samples. And what you're seeing on the left is a measurement for the insulin receptor A isoform shown in purple. And that's just a staining for the nuclei of cells. And you can see a lot of insulin receptor A expression in this tumor section. This also allows us to see if there is some heterogeneity in the expression of these markers in patient samples. On the right is a sample from another patient. And here we have tested it for both IGF receptor in yellow and the insulin receptor A isoform in purple. And as you can see, there is expression of both markers in this particular tumor samples. We are now multiplexing this to add other markers of NK cell function, as well as other markers that we feel might be useful to develop as biomarkers of response to these strikes. Next slide, please. So in summary, our data suggests that the trikes activate human NK cells from normal volunteers to kill triple-negative breast cancer patient-derived organoids. We are now continuing to test the efficacy of both these trikes against more patient-derived organoids, and we will also test them in tumors in preclinical models. And the other thing we want to understand is that, can we take an NK cell from the patient itself, and will they kill these tumors? So we are right now banking NK cells from patients with triple negative metastatic breast cancer. And we are going to test to see, can we take NK cells from a patient and use it to kill the tumor cells from that patient? Because that's what you would see in a clinical situation. You would want a patient's NK cells to be activated by the drug and kill the tumor cells. So that's where we are with the research on this project in my lab. And I just want to conclude by showing you that today, treatment of advanced triple negative breast cancer has a lot of choices. So when you're diagnosed with triple negative breast cancer metastatic, you will first be tested for the expression of PD-L1. And if you have a PD-L1 expression, you will get treated with pembro or another immunotherapy in combination with chemotherapy. And in a second line, you can also now receive the ADC that we talked about, sacutumumab govitecan. And then we have now also got choices in the third line setting, including new ADCs, other chemotherapy agents, as well as other immunotherapy agents. Last slide, please. And so in summary, I want to just leave by saying that triple negative breast cancers are considered to be more aggressive and have a poorer prognosis than other types of breast cancer. The majority of patients with early stage triple negative breast cancer should be treated with neoadjuvant therapy. In recent years, multiple advances have made the management of triple negative breast cancer, including neoadjuvant immunotherapy with chemotherapy, the treatment of early stage disease, and also the approval of many other drugs in the metastatic disease. Triple negative breast cancer is a heterogeneous disease, and exploiting that heterogeneity will guide new targeted approaches to creating new therapies. And finally, NK cell-based strategy is a potential future therapeutic approach. Next slide, please. And I just want to end by thanking the people in my lab who did the work. All of the NK cell work was performed by the 3 people in my lab. And next slide, please. And this is the 2 of them that did the bulk of the NK cell work that I just presented today. I'd like to thank you for your attention.
Thank you so much, Dr. Sachdev, for that thorough overview of triple negative breast cancer, but for also breaking down the science in such a digestible way. It is so exciting to see how discoveries that are happening here in Minnesota are advancing understanding and treatment of triple negative breast cancer, but also addressing the disparities that we see that continue to affect so many women. So now we are going to turn it over to Katie Lin, whose story is going to remind us about why this research is so deeply important. So Katie, thank you so much for being here today and for your willingness to share your cancer journey with us. And I will now give you the virtual floor.
Sounds good. Thank you, everyone. Good afternoon. So actually just 12 years ago yesterday is when I was initially diagnosed with my early stage breast cancer. And at the time, my biggest worries were raising my toddler and finishing up some large projects at work. I had never imagined I'd be sitting here in front of you today talking about cancer, but yet here I am. What I like to call myself is a thriver. A mom and someone who's still exploring, trying to live life fully. So at the time, my son was probably still thought that Band-Aids really fixed everything. And here I am being diagnosed with early stage breast cancer. And that moment really changed everything. And I'm going to share a little bit of that story with you here today. So with my early stage diagnosis, I actually wasn't diagnosed with triple negative breast cancer. It was a hormone receptor positive breast cancer. I was 28 years old at that time, and due to my age, I opted to have a bilateral mastectomy, and then I went through, I think, 4 rounds of chemotherapy with my early stage breast cancer diagnosis. Everything went smoothly, and I think it was right around my 5-year mark of being diagnosed. Things, slowly turned back to normal, and then I was at routine appointment with my oncologist, and I had mentioned I had a cough that kind of started coming during a recent trip to Japan, and we didn't really think much of it, but Dr. Yi, my oncologist, had ordered an X-ray just to be sure, to just see what's going on. And to our shock, my cancer had spread to my chest, I think what they call a mediastinal mass, and in my lungs. And so that changed everything. It was a triple negative breast cancer when it recurred, which was kind of mentioned today, targeted therapies and hormone treatments were not really an option for me this time. And to be quite frank, at that time, it felt very aggressive, very isolated, and way more frightening than my initial diagnosis. During those early weeks, I spent a lot of time thinking, how did I get here? What do we do now? And I realized like the fear at that time was very normal, but it didn't stop me from living my life. So a little bit about kind of what I went through with my metastatic diagnosis. I initially went through chest radiation. I think it was a couple weeks I went through daily treatments of chest radiation right to the center of my chest. And that was followed by chemotherapy, which was carboplatin and Taxol. I went through actually many treatments. I used to joke with my chemo nurses that I was going to beat some sort of imaginary record for the number of sessions I went through. I don't know if I actually ever beat a record, but I think I got somewhere into the 40s with number of treatments. They're initially, I think they were weekly, and then it got a little too tough for me, so we switched it to bi-weekly. And luckily with every scan, my tumors kept shrinking. And then I think it was right before the pandemic started with COVID, I was hospitalized because of my chemotherapy with a mystery illness that we never really solved. I got out of the hospital, and then soon after that, I broke one of my toes. And so to give me a bit of a break, since I'd been through so many treatments, we decided to take a break to let me kind of heal a little bit. And we decided we're just going to take some scans and kind of watch things for a while. And scan after scan showed no new growth. And surprisingly, since that, I have not returned to my chemo treatments. And so now I'm currently not on any treatment. I am monitored every 3 to 4 months with scans. And during that time, I realized the biggest thing I realized is that treatment isn't just about medicine. I had to show up for myself, trust my care team, and give my body what it needs, which for me was a lot of rest. And then just, take whatever life throws at you, challenges, which includes breaking your toe in the middle of chemotherapy. So I would say for me, the hardest part was really not the treatment. It was actually worrying about my family. Going to chemo is something that actually gave me a purpose and something to do. I just watching my main caregiver, my husband, and my toddler at the time see what I was going through was actually definitely the hardest part for me. And what's even crazier is after a few months into my treatment, I actually went back to work full time. I know that sounds crazy, but it really did give me a purpose and a sense of normalcy. I was lucky enough that I was able to work from home during that time. And right prior to being diagnosed, I was actually expecting a promotion. And so I really was not going to let cancer take that from me. So I did go back to work full time, and I've been working ever since. And I really couldn't have done any of this without my care team and my support system, my family and my friends. They were just I'm so grateful for each and every one of them. And what I would say people ask me most about what helped me is really, I think 3 things got me through treatment was curiosity, gratitude, and connection. I'm naturally just a very curious person. So I asked my team a lot of questions so I really understood what I was going through. When I say gratitude, I was just reminded that there were still a lot of great things going on in my life aside from cancer. And the last thing I mentioned was connection with my friends, my family, and my care team reminded me that I'm still a part of life and moving forward. So kind of where I am now, I may have mentioned this earlier. I'm now 12 years out from my initial early stage diagnosis. And now, surprisingly, I can't believe it, 7 years out from my metastatic diagnosis. And as I said, I'm not currently in treatment, and my scans have been stable ever since I broke my toe. I do currently now, I would say, live in 3 to 4 month increments between my scans, but I would say that's tough, but it's gotten easier over time the further out I've gotten from my diagnosis, and I celebrate every single one of those stable scans. This journey has really taught me that I'm far more resilient and fiercer than I've ever imagined. It's really changed how I view the world. I just feel so lucky to still be here with my family, and so much more rolls off my back now. It's something I jokingly call stage 4 wisdom. So when I was first diagnosed with triple negative breast cancer, as kind of mentioned, things feel very grim for someone when they hear about triple negative. But thanks to ongoing research as shown today, I think things are really changing fast, and new treatments and breakthroughs are giving people like me real options. And so when I think about now, I think about how back then I wasn't sure if I was gonna watch my son grow up. And he was barely, I think, 3 at the time. And when I look at my son now, he's taller than me and has just started high school. And so I'm really reminded when I think about that, that cancer has really taught me to look at the ordinary, embrace it. I'm really game for just a quiet morning. I walk around my neighborhood, and especially those stable scans. It's just perspective is really everything to me now. And if I could speak to myself on my past self on the first day of diagnosis, I just really would say I'm so much stronger than I ever thought I could be. I still have so much laughter in my life, even if it's a dark sense of humor I didn't have before. And I find moments of joy and things I never even expected to find joy in, quite frankly. And so I just really thank everyone for being here and just letting me share my story with you all. So thank you very much.
Katie, thank you so much for sharing your story with us today and for being here. And congratulations
Thank
on
you.
hitting the 12-year mark. That is incredible. And so I'm gonna bring back Dr. Sachdev to the conversation. So we have a few minutes for some questions. And if folks have attended previous fireside chats, you know, it is not a fireside chat Q&A without getting our fire started to make things cozy for our conversation. So if you have questions, please drop them in the chat. We will do our very best to answer a few questions that come through. To kick us off, a question came through earlier, Dr. Sachdev, for you. So I will actually hand this one over to you. Is there a connection between triple negative breast cancer and BRCA mutations? What's the link?
Yes,
Tell us
so
all
we
about it.
did. Thank you for asking that question. We didn't go into that, but there are people who have BRCA mutations that get triple negative breast cancers, but they do also have the choice of getting PARP inhibitors. So PARP inhibitors are ones that affect DNA damage. So actually, triple negative breast cancer patients who have a BRCA1 mutation are actually treated with PARP inhibitors like olaparib, and they do fairly well with that in combination with chemotherapy. For time reasons, I didn't go into BRCA1 mutant triple negative breast cancer.
Okay.
Thank you
for
for the
sharing.
question.
Of course. Thank you for whoever submitted this question. And then a few questions have been submitted, and so I'll actually have you chime in on this now. What are some of the preventative strategies that folks can take to reduce the risk of breast cancer and triple negative breast cancer specifically?
Well, so obesity is a risk factor for, I think, all kinds of breast cancer. So definitely that. Alcohol intake. And I would just urge people to exercise, because exercise is the best to fight your, have a better chance. And obviously, if you have a family history of ovarian cancer, something, get tested for BRCA, things that you can control. Some things we cannot control, but definitely exercise, keeping a good body weight, nutrition.
Mm-hmm. And I mean, so the screening age for breast cancer starts at age 40, but Katie, you were diagnosed under the age of 40. What should women under the age of 40 look out for in terms of signs and symptoms, and what to bring up with their primary care provider?
Yeah, so for me, I actually found the cancer myself. I did a self-exam and I noticed a lump in my breast. And so that was my earliest symptom. And so I brought it up to my primary care provider, and they luckily took it very seriously, and I went in for testing. So for me, the self-exams were the most important thing.
And so know your body, advocacy. I think that's kind of the two main things, understanding your family history as well, and making sure that you are staying as healthy as possible, exercising, eating healthy, all of the things to reduce your risk. So thank you both so much for chiming in. So Katie, this question is for you. So what message would you share with somebody who's newly diagnosed or with a loved one trying to support them?
Yeah, so I would say for me, my biggest thing was taking it a day at a time. Um, waking up every morning and taking advantage of every little moment of life is really like what really got me through every day. Um, my husband actually went, when I was initially diagnosed, it was right before COVID. I actually had people come with me every treatment, and I think that really helped me a lot to have a support system there. So if you're a loved one, just even checking in on the person, you may feel like you're bothering them, but you're really not. Just knowing that people are there and thinking about you is, I think, a really big thing that helped me through it. So.
Love that. Thank you for sharing that. I am so sorry, folks. We are out of time, but before we wrap it up, just one quick question I'll have both of you answer. So I'd love to hear one message. So what is one key message that you want our audience to take away from the conversation today? Dr. Sachdev, I'll let you go first.
I want to emphasize that we are making a lot of progress in finding treatments for breast cancer. So don't lose hope. There is always new drugs that would work. And so I want anyone who gets diagnosed to keep the hope.
And actually, before we started the webinar, Katie, you had made a comment about the treatment options that are available now are not like the treatment options that were available to you when you were first diagnosed with breast cancer 12 years ago. So it just kind of speaks to the advancements that are happening.
Yep.
And Katie, what is one message that you want our audience to take away from the conversation today?
Yeah, I would say the biggest thing for me is I live on like gratitude and just embracing just the little things in life. And I know the world feels, chaotic right now, and a lot of us are living through tough situations. And so to just be grateful for every little thing that you have.
Okay, well, thank you both so much for your time, for your openness, sharing your expertise and heart in today's conversation. So these fireside chats are made possible because of incredible speakers like you two, and because of our audience members who continue to show up, to learn, and to share these conversations with their loved ones and communities. So before we wrap up, I just have a few quick announcements that I'd like to share. First, please take a moment to complete the very brief survey that will auto-populate when we close out the session today. It will also be included in tomorrow's follow-up email. Your feedback truly helps us improve our future fireside chats. And as a small token of appreciation for your time, you can enter a drawing to win a prize pack filled with goodies from the Masonic Cancer Center. And second, if you're local to the Twin Cities, or if you would like to tune in virtually, we invite you to our second annual Cancer Free Futures, a community conference on cancer prevention on Saturday, November 8th from 11 a.m. to 4:30 p.m. Central Time at the Cancer and Cardiovascular Research Building in Minneapolis. I just dropped in the link, some information, and the registration link, but this is a free community-centered event where we will be exploring topics such as navigating cancer misinformation, understanding the different cancer screening guidelines, mental health resources after a cancer diagnosis, and also an opportunity to hear about some community-driven cancer prevention research, all with a focus on supporting communities most affected by cancer disparities. And also, there will be opportunities for free cancer screenings on site, including mammography screening for breast cancer, consultations with medical providers for colon cancer and lung cancer. And yes, it is all free parking, free food. And so please, if you're interested, check it out, register. We would love to see you there. And finally, mark your calendar for our next virtual fireside chat on December 11th, same time, same place, to hear insights on pancreatic cancer from a leading expert in the field. We are taking a fireside chat break in November, so I hope to see some of you at Cancer Futures on November 8th. I knew I just threw a ton out there, and you heard about some of the latest research that's happening at the Cancer Center. So to keep up with everything that's happening at the Masonic Cancer Center, please make sure to follow us on social media, or you can subscribe to our monthly newsletter for some of the latest research, updates, and event announcements from the Office of Community Outreach and Engagement. Thank you all for being here today, for spending part of your day with us. Until next time, take care and be well. Bye now.
Bye. Thank you.
All right, thank
Thank
you.
you.